we are going to be having a quite interesting session where we're going to be discussing hospital-based Sentinel syndromic surveillance to monitor COVID-19 pandemic. We're going to have one of our speakers, Dr. Ambrose Winnie, who is going to speak to us on matters monitoring the COVID-19 pandemic during this season. You are welcome to join us. Feel free to participate in the Q&A session. We'll be starting in 2 minutes time. We'll give people time to join in by 5 minutes past 2 p.m. We'll be starting off the session. Welcome. Feel welcome to join us and to participate. Thank you. Joining us for this webinar, whereby we are going to be discussing matters on monitoring the COVID-19 pandemic in Kenya. We'll be discussing on hospital-based Sentinel syndromic surveillance by Dr. Agweyu, who will allow to introduce himself. For those who will be seeking the CPD points or you have any issues with the CPD points, kindly email knhcpd@gmail.com or cpdpharmacy@gmail.com, and we'll be able to respond to you in regards to issues on CPD. For this session, we welcome you to join us to ask your question, to give your comments in the Q&A session, and we'll be able to get back to you as we have this discussion of monitoring the COVID-19 pandemic in Kenya. And right now, as we have discussions on how the curve is doing, how the COVID-19 is doing, matters testing, matter surveillance, how do we beef this up and how do we monitor the COVID-19 pandemic in our current situation here in Kenya? You are welcome. My name is Dr. Agnes Karingo Karume from Kenyatta National Hospital. I'll be moderating this session, and feel free to join us to actively participate. Thank you. I now welcome Dr. Ambrose Agweyu to introduce himself and go on with the presentation.
Good afternoon, and thank you, Agnes, for that introduction. Thank you to the organizers for convening this important meeting. It's been a true pleasure presenting to colleagues and peers across the country and learning from the broad range of experiences from presenters during these webinars. So huge congratulations to you, Dr. Agnes, and colleagues, Dr. Thuranira, Dr. Chieng, Dr. Kinuthia, Dr. Marybeth, and others. This is a platform that we really should try and sustain even beyond COVID as a means for sharing and learning among peers and colleagues. My name is Ambrose Agweyu. I'm a pediatrician and epidemiologist by training. I work with the Kemri Wellcome Trust Research Program, where I head the Department of Epidemiology and Demography. And I also work with a team that is called the Clinical Information Network that forms the basis for the discussions, which I'll be presenting and hopefully getting some feedback from you on today. So over the past decade, we've discovered as a team within the Clinical Information Network that it's possible to achieve high quality care and sustain team and individual level change in management for children presenting with severe illness to hospitals, public hospitals in Kenya, through the efforts of a network of engaged partners. I want to spend about 30 minutes sharing our experience establishing this community of practice for learning and improvement and the process of adapting it for use for COVID surveillance and some of the findings and utility of the data that have emerged. So as a background, and I've lifted this screenshot directly from the outputs which Dr. Kasera's office releases daily. This is what was shared from yesterday. And you can see from this slide that the ministry reports that just over 500,000 tests have been done cumulatively since the outbreak landed in Kenya. And of these, we've managed to identify 36,981 confirmed cases to date and 648 deaths. You can see from the epidemic curve on the right that those in orange, I think it's orange, it should be identified as those who are asymptomatic, and those who are shaded in blue are those who were symptomatic at the time they were diagnosed. And you can see there's an overwhelming predominance of asymptomatic infections as per the case data which are reported from the EOC. This raises important questions around whether we are ascertaining severe cases adequately across the country. So why should we then undertake hospital-based Sentinel surveillance? Decisions around reopening the economy are balanced against the risk of a surge in cases overwhelming our health system and a resultant excess mortality. This is really what you frequently hear referred to as flattening of the curve. This curve we're trying to flatten it so that we don't experience a surge that will overwhelm our health system and that we don't have excess deaths as a result of this. So really, there is the government, like many other governments, are facing this dilemma of continuing to apply these mitigation measures in the context of an unknown future of the pandemic. Because on one hand, if you release the mitigation measures, then you might experience a surge in severe cases, and this curve might then peak again. So it's a tough decision, and I guess it's our role as partners to the ministry, academics in the country, to do what we can to help contribute to inform important decisions such as these. So within the Clinical Information Network, I mentioned at the introduction, we've developed a partnership that has grown and evolved over time. It comprises the Kemi Wellcome Trust Research Program, the Kenya Pediatric Association, the Ministry of Health, primarily through the Division of Neonatal and Child Health, and county governments and the hospitals which are participating in the network from those counties. The focal people in these hospitals who are really at the core of the success of this platform and whose efforts need to be acknowledged and credited are mainly the pediatricians in the pediatric units, the health and records officers in the respective hospitals, and we have active participation from the nursing officers in charge of the pediatric units, but we also enjoy support from the hospital management themselves and the counties as well. So this platform has been active in was active in 14 sites in 2013, has expanded since and now covers 20 public hospitals, representing 15 out of the 47 counties in this country. And the focus of the intervention for the network is to improve data capture and the use of the data to inform quality improvement through audit and feedback. So how does this work? So the data are captured from the hospitals, and it all really begins with this frontline health professional who is usually a medical officer intern or a clinical officer intern. We know that these are the people who provide primary services or are first to see patients in many of our hospitals, public hospitals in this country. We have a guideline document that's issued by the Ministry of Health, which forms the basis for the care they provide. And then they provide care to patients based on these guidelines and document that in structured forms, which are basic checkboxes, which the clinicians then basically tick for the absence or presence of certain signs and symptoms. And so this then provides useful data that can be directly entered into a computer which is based at the hospitals, which has open source software running that can be used to enter the data, run error checks, and eventually synchronize the data centrally to our team in Nairobi. So this is happening at all 20 hospitals, but the synchronization is happening centrally at the hospital, at the central site in Nairobi. Please note that the only real investment we have in this platform is the data clerk at the hospitals and a computer. The focal people who I mentioned, the pediatricians, the records officer, the nurse in charge, they work at no fee, and it's part of this community of practice which we've developed, and it's been quite successful to date. And it speaks to really the efforts and desire among health professionals in this country to provide good quality care when they are motivated through a community, an active community of practice. So the data are synchronized centrally, and then they're used to generate routine reports, which are issued every 3 months to the hospitals. Some of the data can also be used for research analysis. There are many people who have done their master's projects using these data, both from the counties and from local institutions and external partners as well. If you're keen on discussing this further, I'd be happy to talk after the presentation. And then the reports are fed back to the hospitals to give them a picture of how well the care that has been delivered by this frontline health worker and others at the time of admission has been. We engage through we used to engage through face-to-face meetings. After COVID now, it's mainly webinars. We had one recently, and we were proud to host Dr. Mary Beth and other physicians at that event. And the hope is that through platforms like this, we'll continue to explore ways in which we can expand or engage wider than we're currently engaging. We call and we have site visits when it's possible to troubleshoot if there's a problem with the platform, but it really is an active engagement that goes beyond sharing a 3-monthly report. There's a WhatsApp group which is quite lively as well. So this platform has then enabled some of the care provided to improve over time. You can see on this chart, this is specifically monitoring HIV status. The hospitals themselves define a target which they want to achieve, and we monitor this over time. And you can see here that the black dots represent the median performance, the gray dots represent each individual hospital, and the gray lines represent the upper and lower interquartile bounds. And you can see it started low, it increased, but there's still wide variation. There's some hospitals which do better than others. But the idea is for the good hospitals to pull up the hospitals which are struggling. This is a similar chart for measuring mid-upper arm circumference, a standard screening tool for assessment of nutritional status in young children. Okay, so now on to how it has been adapted for COVID surveillance. The same system, this same platform has been modified in various ways to allow us to then capture data that can be fed to the Emergency Operations Center. We, for one, expanded the tool to adult wards. The CIN has typically been a pediatric inpatient network. Now, with COVID, it necessitated expansion to the adult wards. The data are now also shared with the Emergency Operations Center through monthly reports and a real-time dashboard that's been developed internally, and we continue with our engagement through Zoom as well. So the surveillance that was established was primarily founded around three broad objectives. We wanted to track the trends of admission and outcome for suspected cases of severe COVID in participating county hospitals using historical data as a comparison. We wanted to also track the quality of care provided within these hospitals in a similar way to what we've been doing with the Clinical Information Network. And eventually we're keen to see whether we can monitor resource needs against hospital workload for COVID case management in the participating hospitals. This is a timeline illustrating the journey towards setting up this surveillance platform. As I mentioned early in March, we had a formal request from the Director General's office to support surveillance through this platform, recognizing the successes of the Clinical Information Network. So we went ahead and began engaging the counties and the hospitals. We reached out to county directors for health in the participating counties, the pediatricians, the physicians, the health records in charges. I expect with over 400 participants in this platform right now, some of you might actually have been engaged in this process and have actively contributed to the outputs of this platform. We also worked with the Ministry of Health to adapt the case investigation form for inpatient surveillance. And in April, did some piloting, sensitized and trained the staff on the importance of the surveillance, the use of the case investigation form, and distributed the form and supplied some very basic essential PPE to complement what the counties were already providing for those who would be involved in the surveillance, and then began the prospective data capture. Again, just to note, this is purely through the efforts of the individuals who are engaged in this activity. We didn't recruit a team of surveillance officers. We were basically working with the infrastructure, the basic infrastructure that supports the Clinical Information Network. And so again, credit to those who are involved, and a demonstration that you can achieve something useful without necessarily investing huge amounts of money and effort. People are motivated intrinsically to support activities when engaged and when they feel that it's of value. We started the retrospective data collection in June, and we issued our first report to the EOC, the counties, and the hospitals in the same month, and we've continued to do so since then. These are the participating hospitals. You can see in blue pins represent participating hospitals, red pins represent CIN hospitals, which are not yet part of the COVID surveillance activities, but continue to actively participate in the Clinical Information Network. Okay, so now some results. I said that the first objective was to track trends in admission and outcomes over time. This is crude pooled data capturing monthly routine reports from the hospitals, captured from individual patient records over time since January 2018. So the importance of looking back in time is because we know that hospital admissions are very seasonal. If you just looked at the period covered over this year, you would notice, you might notice a signal, but that might not necessarily represent an increase or a decrease unless you viewed it against the historical data from a similar period in the past. So in this figure, the green bars represent inpatient mortality. And this graph is specific to adults admitted to the participating hospitals. You can see adult inpatient mortality is actually quite high across over time and across hospitals. We've seen this. So this is pooled across all the hospitals that are participating, but you can see it fluctuates around 20%. You can see from the yellow or orange lines, these are the absolute numbers of inpatient deaths. And then the blue line represents the absolute number of admissions or discharges, in this case, from the same hospitals. What's important to see here is that shortly after March, there was a significant dip in the admissions. And this continued through April. And then from May, there's been a slight increase since then. We're not sure of the trajectory this increase will take, but important to note, it is comparatively, if you look at it against previous years, not higher than what we've seen in previous years as of July this year. This is important because it touches on the big question around flattening the curve. Remember, we said flattening the curve is really around ensuring that our health systems are able to accommodate the increase that might be due to COVID, the increased demand for health services due to COVID, and specifically severe forms of COVID. So it doesn't look like our hospitals are seeing more patients than they've seen in previous years, at least as of July. There is, historically, you can see that there are fluctuations, and it's hard to, if you look back, you might find that there was a strike sometime that resulted in an overall decline in admissions. We know that those have become important and regular challenges within our health system, whose solutions we probably need to discuss in detail at another forum. So that's the adult wards. In the pediatric wards, it fluctuates quite a bit more. But also important to note is, and I was surprised by this actually, that inpatient mortality within pediatric wards is proportionately significantly lower than what we're seeing in adult wards. So there it's oscillates around between 5 and 8%, reaching 10 in some instances. Again, after March, there was a big dip, and it's continued to be low within the hospitals which we have been monitoring, and it will be important for us to continue to track that in the context of what we've seen in the case data, which suggests that there's a decline in cases, but because of the challenges with testing, the populations which are being targeted for testing arguably being lower risk than those who are tested in previous months, it will be important to continue tracking this over time. Interesting that for pediatrics, it looks like there was a bump in admissions earlier in the year, and then the numbers dropped. Your guess is as good as mine as to why these numbers have gone down. It's very likely because of challenges with care seeking under the current environment, stigma and fear that have affected our health services, and it remains a challenge in the context of trying to maintain essential health services in the context of the COVID pandemic. So beyond just counting admissions and deaths, we've also tried to track the individuals who are detected as cases within the participating sites. We have not put in any resources directly into testing for COVID within these surveillance sites. So this is essentially the efforts from the county teams and partners who might be supporting testing. And we focused on this criterion B from the national case definition, which includes patients with severe acute respiratory illness in the absence of an alternative diagnosis that fully explains the clinical presentation. And you know that in our county hospitals, it's very difficult to fully exclude alternative diagnoses. So in theory, this would include all patients admitted with severe acute respiratory illness. This is a chart from data from August, and we've reported here the total number of patients admitted across the hospitals, those who qualify as having severe acute respiratory illness, those who are swabbed and tested for COVID, and those who test positive across the sites. You can see up to a third of patients admitted to the hospitals from the adult wards present with signs or symptoms consistent with severe acute respiratory illness, and a smaller proportion of those actually get a test, and those who test positive are in red below. Important to note, though, that August is actually an improvement over previous months. There was very little testing happening in earlier on in the pandemic. With the current shortage of test kits, it would be useful to correlate this with what experiences from those in the counties is in terms of the changing trends in testing. One of the other objectives was to look at the care provided. And so beyond just testing, we want to see how our patients assessed. And this is the kind of reporting which we've been doing within the Clinical Information Network, sharing these data with the focal people, the heads of departments, to then give feedback to their clinical teams. Here you can see of those who had severe acute respiratory illness, we are able to track documentation of blood pressure, assessment for oxygen saturation, respiratory rates, heart rates, and temperature as key vital signs. We also track some basic investigations which should be available in our county hospitals, and we're able to report those who are hypoxic and those who receive oxygen if they are documented to have hypoxia via SpO2. And here you can see we report 2 months side by side, and we also report what is observed within a hospital and across the hospitals that participate in the network. So this is pooled data across the sites involved in the surveillance. And you can see with July on the right and August on the left, I think there was some improvement across all indicators. We use a color-coded system. We're still not at green for many of the indicators, and this feedback continues to be shared with the hospitals, except for those who tested positive for malaria and were admitted having received artesunate, which seems to have improved into this green territory. We share these results with the EOC. We share them with the counties. We share them with the hospitals, focal people as monthly policy briefs. And as I said, we also interact virtually. And it's been a very rich learning experience and a pleasure working with colleagues across the country to achieve this. Finally, really the ultimate goal for this exercise would be to be able to predict where the pandemic is heading. And the colleagues who work in the same department as me, who are involved within a wider platform hosted by the ministry that aims to model the pandemic, fit predictive models to tell us where we are in the epidemic. And these teams are relying on various sources of data. So the clinical surveillance is just one of the sources of data, the MOH case data. There's serosurveillance work, which I'd be happy to discuss at a separate session if available. There's data that comes from Google on mobility and sequencing data, and all these come together towards helping us refine the predictive models to tell us where we are in the COVID-19 epidemic in the country. So what the data seem to tell us is that we've avoided this anticipated surge in severe cases and deaths that has overwhelmed health systems in many high-income countries in this first wave. So far, we haven't seen hospitals overwhelmed with admissions and deaths as was seen in Europe and in the US. But it's important also to note that hospital data are sensitive to care seeking, and this seems to have changed during the course of the pandemic. The location of these hospitals, as you saw from the map, is not nationally representative. It would be great if we had data from other sites across the country. And if there are those on the call who might be interested in discussing this further, I'd be happy to take this offline. The quality of retrospective data can be argued to be questionable. There are missing fields and files that couldn't be retrieved from the archives. But the platform which we've created has really strengthened the quality of data that we see. So through use of these admission forms, working closely with the health records departments in the hospitals, we've managed to see a fairly good quality data coming from the sites, which we then which then undergoes further cleaning and contributes to this analysis. I think what this really highlights is the urgent need for data from the communities to correlate what we're seeing at hospital level. There are people who are concerned that there could be excess mortality that has occurred in the communities. Again, there's really, what you'd ideally want is reliable data from the civil registration and vital statistics. But the quality of that data has been and continues to be a challenge. So overall, if there is one rally call that this pandemic has shown us, is that we really need to invest in routine health information systems as a priority to provide us useful, reliable data for planning and preparing for the current and future pandemics. This work has been the product of very, very, very many people. I might have even missed out some from this slide. I acknowledge all of them, and thank you for your attention. I'll stop there and hand back over to you, Agnes. Thank you.
Thank you very much, Dr. Ambrose, for that timely presentation. To our viewers, thank you for joining us. And for those who came in a bit late, we are discussing hospital-based Sentinel syndromic surveillance to monitor COVID-19 pandemic. We've just had a wonderful presentation from Dr. Ambrose on how we can monitor the data that you're getting in the hospitals to be able to better prepare and respond to the pandemic. I'll give over to Dr. Mary Beth Maritim to make her comments in regards to this topic. Dr. Maritim, are you with us?
Good afternoon, everybody. I didn't even realize my camera was on, and I've just been walking up and about towns running some errands. But thank you so much, Ambrose, for that excellent presentation and really telling us where we are in terms of the numbers that we are seeing, more so from the counties that are reporting as part of your clinical network. It's very interesting to note, and basically what this does is really to help collect a lot of data from different sources and to triangulate what we are currently seeing, because we really feared for COVID, and we feared that Africa would be adversely affected. But from the data that you're sharing with us, it actually shows that we've had cases, but we've been able to flatten the curve, and this is really very encouraging. And even as we continue to have more reopenings of different sectors, I think the data from your network will really be important, because it's able to track from really the different hospitals what is the situation that's happening across the country, to really give us the true picture. And I think your data will also be important should there be a need to urgently intervene, should the numbers start now to increase. For example, when schools are reopened and other sectors, because we know that school reopening will really be accompanied with widespread reopening of other sectors that support school. For example, more travel, maybe the curfew will be lifted. So there'll be a lot of interactions in the night, and this will really help us to see the trends and the figures as maybe should the cases start. We cannot explain what is the biological factor that is contributing to like less COVID cases in Africa compared to what had been predicted from the models and even from other settings, considering that Africa really has convergence of so many factors that were going to complicate issues. So I think your data is very, very important, because it provides that surveillance in what I'd call like mashinani, like settings that are far and wide and distributed within across the different parts of this country. So thank you so much for sharing. I'm still interested in getting our hospital to be to actively participate in the network. And I think through this presentation, I'd like even to encourage maybe other physicians, because like you clearly said, your network has really benefited from the support from the pediatric team and the other pediatric, the Kenya Pediatric Association. So really to encourage the physicians who are on this call to try and be part of the network, even if your facility is part of the pediatric network, the CIN, then to even have full participation and involvement of the physicians, because your network is really very, very powerful. So thank you for sharing with us the data and the presentation, and it's very encouraging to note, and particularly even to see when you talk of the decline in the number of adverse outcomes, for example, even in the pediatric wards, maybe the hand hygiene and other measures that have been instituted as part of COVID have reduced or have contributed to reduction, maybe in diarrheal diseases and other diseases that would be related to hygiene. And maybe as we go further, these are measures that need to be sustained even beyond COVID-19, that people can wash hands consciously. The masks are important, especially for respiratory diseases. I can't explain how the masks have benefited the adults because, the children, because we know that most infectious diseases move within households, and the children are the people who maybe would contribute to that magnification of the infections within the household, because they pick the viruses in school, bring them home. But in this case, we have the adults wearing the masks, and it seems that even the children have benefited from the adults wearing the masks. But these are things that need more observational data to really contribute and maybe even generate topics for more exploratory research to see, because even beyond COVID, it may be beneficial to continue wearing the masks, because we have definitely had a reduction in respiratory tract infections, things like influenza and other respiratory tract infections, because of the benefits of the mask. So let me stop there and hand back to Agnes. And thank you, Ambrose, for that excellent presentation.
Thank you very much, Doc, for those comments. Indeed, the data has helped us to be able to prepare more and to see where more efforts need to be done, and that the respiratory illnesses have indeed reduced since the onset of the public health measures. We'll have a comment from Professor Omo Anzala. You're with us. We would love to hear your comments in regards to the same. Thank you.
Okay, thank you so much for giving me the opportunity. Ambrose, we have not seen each other since COVID. I believe you are okay where you are, and all the others. This is a great talk, and thank you so much for ensuring that the system and the program you've been using can be looped into COVID. And as I said last week, and I'm going to say it again, we are now moving into a transition from an outbreak to COVID becoming an endemic infection. And it becoming endemic, what Ambrose, you are doing and others becomes very, very critical. Because what will be happening is that indeed patients will be appearing at the various health facilities in our countries. And we need ability and capacity to be able to quickly say that this is COVID. The definition you gave, the syndromic one, can work, but my prayer is that we should try as much as possible to see whether we can actually equip some of these sites with the ability to do a quick laboratory confirmation. The real-time PCR we do for COVID is not a very good test for outpatient or inpatient at the facilities we are talking about. But last week we were in a very in-depth discussion. There are very good antigen tests, either using saliva or using nasopharyngeal or using throat swab, that are now being validated. And pretty soon we should have antigen tests that can actually be done at the point of care. And if this is possible, then Andrew, what you are doing will come in very, very handy in terms of managing and getting to know what is actually going on at the very, very local level. Because as I've said, we are in a transition from an infection that was an outbreak to an infection that is actually going to be endemic. And since it's going to be endemic, we are going to be pressed very hard to be able to tell the difference between COVID and influenza, because COVID has consequences in terms of infection control, and those are some of the things that we really need to be able to discuss. So really this is an excellent presentation, Ambrose. Let's try and push it. The antigen tests are coming. People have been talking of Gene Expert, but Gene Expert may or may not come. Let's just try and aim at looking at antigen tests that can be done at the point of care that will really inform us as to what is going on, because the general testing that is going on now is unlikely to tell us really where we are going with this outbreak. But the hospitalized, hospital-based surveillance will actually tell us what is going on, because as you showed in that graph, over 95% of our patients are asymptomatic. So really the people we are really going to see are those who present at the healthcare facilities with the case definition, and then thereafter the need to confirm whether they have COVID or they have something else. So for me, this is a big plus. Let us just try and work very, very hard to sharpen that case definition where we cannot test, but also let's work very, very hard to try and see that we can get quick, rapid tests, especially the antigen tests at these sites. Thank you.
Thank you very much, Prof. And thank you, Dr. Marybeth, for those complimentary comments. Just to support your views, Prof, around strengthening our ability to ascertain cases, I think I would be very keen to engage if there were plans to deploy rapid tests that could replace what we're currently, our current approach, which we seem to be continuing to experience challenges using. Rapid antigen tests indeed appear to be the way to go. And I think it would be critical to have this supported through experts as yourself and existing networks externally to help identify which tests would be best for our setting, recognizing that the field is increasingly flooded with options. Thank you.
So Ambrose, we shall keep, let's keep in touch. So as we review the various antigen tests so that we can keep each other posted, because for me, really, just the way HIV went to the extent that there's now self-testing, we want to be able to have ability to have point of care tests for COVID as well. Because from just looking at the various epidemics and pandemics, COVID is going to be with us for a while. And the need to actually have a quick diagnosis, and more so, the relationship of COVID with infection to the healthcare workers. The earlier one gets to know that the patient has COVID, the better in terms of hospital infection control. So let's stay in touch. And as we look at these antigen tests, we'll keep all of us posted so that whatever we believe is really user-friendly to our communities, and those are the tests we shall pick, and then work with the ministries of health and the county government to see how we can deploy these tests. Thank you.
Asante, Prof.
Thank you very much, Prof. Thank you very much, Dr. Maritim, for those comments. Indeed, we need a lot of collaboration, especially in this pandemic. If we get the point of care testing, that would really be a milestone in the care that we give, in the improving the quality of care that we give. Just to start us off on some of the questions, Dr. Ambrose, maybe for a beginning, for those facilities whereby this has already, the data collection and feedback has already been given, what are some of the challenges that they say they are facing, or how has been their uptake on the feedback on the data they collect? And can this be scaled up to maybe other facilities or even nationwide as a means to collect data and give feedback?
Thanks for that question. We've been sharing the reports, as I said, as briefs every month, but we also have had a couple of webinars where we've discussed the findings. And I think especially on findings around quality of care, those are discussions that are best held in a collaborative way. We share the data, but really the solutions are developed by the hospital teams themselves, recognizing the unique challenges they might be experiencing. So for one, I think I'm encouraged that hospitals seem to be very engaged. They take the feedback positively, and it's resulted in some improvement in the care provided. If you look at the assessments for routine patient care tests, or rather examinations, which should be done for all patients, routine investigations like hemograms, which should be done for all severely ill patients. We've seen some improvement from the time when we started the sharing of these reports. We also share these data with the counties and the ministry. I think that there are challenges. Improving service delivery is a huge task. It's affected by several moving parts, not least of which available resources. And so I don't think there are any quick solutions to improving care in our counties, but I firmly believe that this is a good starting point when you are able to share results back to facilities and them internally developing solutions to address the challenges that have been highlighted. It would be easy to scale this platform up to other sites. As I said, the investment at site level is really around the engagement of the focal people. It's not the resource is not monetary in nature. It just takes someone who is ready to champion the improvement of care in their facility and engage in the platform. And that's really how some of the newer sites have joined during this COVID period. And depending on who else is interested, those discussions can be held. Back to you, Agnes. I see your microphone is muted. Hello, Agnes? I think we've lost Agnes. Anyone from the KNH, or is it me who dropped off? Dr. Thuranira?
Ambrose, can you hear me? Thuranira, can you hear me?
Yes, I can.
I can step in for Agnes as she sorts out. There was a question by one of the panelists asking, my observation and belief is that the daily briefs on COVID-19 is just a tip of the iceberg. How then can we be serious and convey the true picture? Maybe you give your comment on that.
I think the answer to that lies in various sources of data, and the coordination role probably lies with the Ministry of Health, really, working with allied ministries as well. We know that we have a civil registration and vital statistics department that's hosted within the Ministry of Interior. There, we're supposed to register all births and deaths in the country. And remember, beyond just the number of cases, what we really want to avert, especially in a country like ours, which is vulnerable to economic shocks that arise as a result of the mitigation measures of COVID, what we really want is to be able to be sure that we are monitoring severe cases and deaths. I think there are discussions within the ministry and through the task force, and I think others on this call, like Prof. Anzala and Dr. Marybeth, might be better positioned to comment on where we are in terms of ascertaining true cases and possible severe and fatal cases from other data sources. So what I've presented is really just one piece in the puzzle. We really need to try and obtain additional data, including that from the community, to help us fully understand the story. Thank you.
Thank you for that. And maybe before Prof comes in with his opinion about that, there's a last question here about how can other facilities join in, and more so private facilities, into this good work that you're doing with your team?
I think the answer to that is you're very welcome. I'm happy to share my contacts after this call and start a conversation with whoever might be interested in engaging. Thank you for your interest.
So before I hand over to Dr. Karingo, Prof, what's your opinion about us getting the true picture of what is happening on the ground?
You know, thanks, Ambrose, for that. And this question is critical. The truth of the matter is that really we are unlikely to get a true picture. And also it depends on what we really mean by the true picture. Because here we have an outbreak where over 95% of individuals who get infected remain asymptomatic. And there is something I've been saying called a silent outbreak. This is a silent outbreak that does not reach hospital and is also not tested. They may have very transient fever, which goes away within days, and they recover. So when you saw the numbers, regardless of what is going on, what Ambrose has actually shown us in terms of hospital admissions is actually telling us the true picture that most people are not ending up in hospitals. Those who are ending up in hospitals are the minority. Most individuals are getting infected. They hardly ever show any symptoms, or if they show, they are very, very minor symptoms. They go off the counter, recover, and move on. The true picture is what Ambrose, they did, the initial work they did among blood donors, which we actually need to do even more to look at serology. That's where the true picture is, to look at community serology and ask, in a given community, how many people are positive for SARS-CoV-2 antibodies. That will give us actually the true magnitude of what number of people are actually already infected and have recovered. But the issue of testing, the way we are testing now, the strategy we are using now is actually not going to give us the true picture. So for me, really, if we can also get very good serological assays and then begin to do community serosurveys, and to ascertain in various communities, that will give us a true picture of how many of us already show seropositivity. And that will mean maybe, I'm just guessing, maybe by now, the 4 million people in Nairobi, maybe even 50% of us have already got transient infection and we are showing some level of seropositivity. That's where the true picture is going to come from. So if Ambrose can begin to package, if they have that serological assay again, or we again look out and get another serological assay, and again now, instead of using blood banks, just do community serosurveys, that will actually be the true picture. Then now the worry is, once you are infected and you have recovered and you show some seropositivity, are you likely again to be susceptible? That is now the question we are trying to answer by looking at neutralization capacity or neutralization ability of the samples we are getting from Bagathi and from KNH here, as well as from Mombasa. Thank you. Maybe Ambrose, you have a comment on community surveys?
Ambrose? Seems Ambrose might. Ambrose, oh good. Ambrose, unmute your mic kindly.
My
Dr.
apologies.
Ambrose?
Yes, sorry, I dropped off. My internet connection dropped. I'm not sure where I left it. I might have been speaking.
Yeah, Ambrose, what I was saying that the stage where we have reached, the true picture is really going to look at community serosurveys. We need to ask ourselves how many of us as Kenyans have been exposed, got infected, recovered, maybe didn't show any signs and symptoms, what percentage of communities have serological positivity? Because if we use the testing strategy that we developed for the ministry, which is actually not being followed, we are really not going to get a true picture. So I wanted you to tell us, you had done blood banks. Are you also planning to do some community sero surveys to give us a sense of what percentage of us already shows seropositivity? Because to me, that's where the true picture will come from.
Thank you, Prof. I couldn't agree more with you that the qPCR testing will continue to only reflect a tip of the iceberg and a biased tip of the iceberg for that matter. As you mentioned, the blood donor serosurveillance has been ongoing, and we continue to collect samples with the Kenya National Blood Transfusion Services, but that data has its limitations. People donate blood for different reasons. The age group which would be eligible for blood donation leaves out almost half of the Kenyan population who are under 15 and over 64. So there is need to look at other populations. And with the current situation, it's been challenging to do population-based work, but ultimately that's where we want to collect reliable age-stratified data to give us a true picture of the seroprevalence and cumulative exposure to the virus in the population. As other proxy sources of data, we've been working with Dr. Thuranira leading work in looking at seroprevalence among other populations, including ANC clients, healthcare workers, other PCR positive individuals, both those who are symptomatic and asymptomatic. And this latter group is important in helping us interpret serology findings more generally. We know that antibody kinetics vary over time, and to help interpret seroprevalence data, we would be keen to see how antibody levels change over time in individuals, because there are ongoing debates around waning immunity. So if an individual was positive for seroconverted, perhaps in March, there are emerging literature that suggests that months later on, they might no longer have antibodies detectable and detectable levels. So looking at the kinetics of antibodies in symptomatic and asymptomatic patients will help address and perhaps adjust the findings from these other seroprevalence surveys. Hopefully we will be able to share results on some planned work within the Kilifi demographic surveillance system. But Prof, as you've said, really what we would want is something national. And that's a huge undertaking that costs significant time and funding, which hopefully we will eventually be able to obtain. But until then, we might continue to rely on these proxy sources of data. Thank you.
That is on the issue of longitudinal follow-up of seropositivity. We have already started that work. So we've been picking samples from individuals who have already recovered from COVID on a monthly basis. So there are individuals now, we have a couple of samples post-COVID recovery from Nairobi, from Mombasa. So we are going to actually look at the issue of just the dynamics. What is the height and how quickly do these antibodies drop? And also what we are also doing is that coupled with that, we also have capacity to look at ability for these antibodies to neutralize, whether they are neutralizing antibodies or they are just binding antibodies. So this data is coming in. We have collected maybe from 30 individuals now, but that is still a small number. But nonetheless, that is a kind of information that will also give us a proxy as to, in our population, what kind of, once you get to recover, what percentage of us are seropositive, and maybe how quickly do these antibodies wane off? And also, are these antibodies just binding antibodies, or are they neutralizing antibodies? So this data is coming in, but rather slowly because of validation of assays and what have you. But nonetheless, Sud is sending us information. We are getting data samples from Bagadi. We are getting samples from KNH. So within the next month or so, we should have some preliminary data to be able to present. But nonetheless, community surveys will have to be done, Ambrose, and I'm sure with Cambry Welcome, you guys should be able to help us on that. Thank you.
Thank you so much, Prof. and Dr. Ambrose. I think my last question to the two of you would be, we expect the president to address the nation this week, and with all the mitigation factors, that measures that have been put in place and what has been going on. I'd wish just a brief comment from both of you on what you think, or what would be your advice as we move forward as pertains the mitigation factors that have been put in place. Thank you.
Maybe I should go first because I know Prof will have a more profound response, and my perspective is somewhat limited. But thanks for that difficult question, Dr. Thuranira. In my view, I think the ministry would, and the government more generally, I hope, will be keen to look at the evidence, look at the data from various sources, and then use that to then inform policy. I think earlier on, we had very little data to go by. And so a lot of the estimates which we were generating were rather imprecise. And as time has gone by, we continue to have more and more information available. The teams which are involved in the modeling have more data to work with. And it's my hope that that data will contribute to decision making. It does seem like the cases have gone down over time, but if there are decisions around reopening schools and other relaxation of other containment measures, as Dr. Marybeth mentioned earlier, then there's bound to be an increase. So I would, my response to your question would be that even as we consider relaxing these measures, we really need to continue monitoring closely using data sources such as this clinical surveillance data, using data from seroprevalence work as well to update our planning and allow for timely response, so that if we need to lock down, again, it's based on objective data as opposed to various imperfect sources, which often, unfortunately, tend to take the day. Thank you.
Okay, thanks, Ambrose. So Serena, for me, my position would be that I think we've been listening to our colleagues from the counties, and all we hear is that counties have one single problem: ability to test. That's one of the major problems. From what we have been hearing also from many counties, and those ones that seem that were going to be overwhelmed, like Kiambu, Kajiado, Machakos. The last meeting we had on Friday is that really they are in a state of where they are actually managing. So the issue will be, can the president be given very good information from the counties of their level of preparedness, but more so, are they able to access a test quickly so that when we are told about 24 hours, really these samples were collected in the last 24 hours. And then, do they have any ability to contact trace? All right. Do they have ability to isolate? And do they have ability to correct? And why do I say this? I say this is because if you look at the data, you can actually see that counties are beginning to increase in numbers, but very, very slowly. So we want to be able to still have very active ability to test, ability to isolate, ability to contact trace in the counties, just the way it is in Nairobi. And if it can be ascertained that in majority of counties these things are in place, then my suggestion would be let's ease some of the restrictions that are already existing. But with the realization that should we figure out a place or a location or a sub-county where there's a surge, then immediate restrictions can actually be put in place. That will actually be my advice to the current status in which we find ourselves. Thank you.
Thank you so much. Dr. Karingo, are you there?
Yes, Doc. Thanks.
All right. Over to you. Thank you.
Indeed, thank you very much. Our panelists, thank you so much for your comments, Prof. Anzala. And thank you also to Dr. Turanira for coming through. I dropped off at some point. Thank you, Dr. Ambrose Ngoyi, for taking us through this timely session. Indeed, use of data is very important at this time to be able to know where we are and how we can move forward. We cannot underscore the importance of the surveillance, of the data surveillance that we need to do in order to have this information to make, in order to make the policies and in order to have the correct directives, even in this pandemic period. We're now coming to an end of our session. We thank our panelists for being with us till this time, till the end of this, and we thank you for your comments and your questions. For those who are still asking about their CPD points, kindly email the emails given, the knhcpd@gmail.com and the CPD pharmacy at gmail.com, and you'll be able to get a response probably by the end of the week. We'll be having continuous sessions going on this week, starting tomorrow in the evening at 7 p.m. Note the dates from 7, not the time, from 7 p.m. to 8:30 p.m. We'll have a series continuing on primary immunodeficiency disorders, which will be going on Tuesday, on Wednesday, and on Thursday, before having a final session on Friday at 10 a.m. where we are going to be discussing on the COVID-19 in the counties. So thank you very much for joining us. We'll now have a final comment from our presenter, our main presenter today, Dr. Ambrose Ngoyi.
I really don't have much to add other than to thank you, Agnes, for hosting this session, and to the rest of the organizers for this session and prior sessions as well. It's really revolutionized how information is shared among practitioners in this country, and the fact that you've adapted so rapidly to this new situation is testament to how responsive and innovative the KNH and UN research teams are. I want to thank also especially Prof. Anzala, who's my teacher and a mentor in many ways, for making time for this, and other senior colleagues who find time to contribute to these discussions and share their insights that ultimately shape the way we proceed to contribute towards this national response, and more generally, the way we practice medicine in our various areas of work. Thank you also to the audience. I see over 500 people joined, and I look forward to taking forward some of the discussions that have come from this meeting separately for those who are interested in working, collaborating in future. Thank you very much.
Thank you. Thank you for that. We've now come to the end of our session. Let's meet tomorrow for the talk of immunity, primary immunodeficiency disorder. Thank you everyone in absentia. Also thank you Dr. Maritim who gave us comments earlier. Thank you, have a lovely afternoon.
Thank you too.
Asante, thank you.